We're dealing with advances in surgical techniques, and we're talking about the laparoscopic and robotic surgery. In this section, we'll deal with the post-operative care of a patient who has undergone minimal access laparotic or robotic surgery. We'll first deal with the principles of electrosurgery, which can damage a patient during this minimal access surgery. Then we'll talk about the general principles of the post-operative care, and then we'll see the further developments in minimal invasive surgeries. So, what are the principles of electrosurgery during laparoscopic procedures? So, during the laparoscopic procedures, electrosurgery can actually be quite damaging to the patient. So, let's see how can that occur. There can be touching or grasping of tissue during current application. So, you were trying to electrocauterize a certain thing, and there was some touching to an unwanted tissue, so they can cause damage. Then there's direct coupling between a portion of bowel and a metal instrument that is touching the activated probe. So here you can see this is the activated probe, and the bowel can there can be direct coupling between the bowel and the portion and the metal instrument that is touching the activated probe. Then the insulation can break in the electrodes, and hence the breakage of insulation can cause unwanted electrosurgery. Then there can be direct sparks to the bowel itself from the diathermy probe. Then the current passage to the bowel from recently coagulated electrically isolated tissue. This can be the cause. So in all of these causes, the importance is the electrosurgery can be damaging to the bowel, to the tissue in which it comes in contact with. So one should be very, very careful while using the electric diathermy or the electrocautery. Now, how do we manage the post-operative care in these patients, in patients with minimal access surgery? So these are the basic surgical principles actually. The meticulous care in the creation of pneumoperitoneum should be undertaken. So one should be very careful in the creation of pneumoperitoneum. Then there should be controlled dissection of adhesions. So there should be limited dissection of adhesion so that only a tunnel is formed towards your specific part of the abdomen in which you have to perform your surgery. Then adequate exposure of the operative field should be there. The basic surgical principles always include that. Then you should avoid and control bleeding. Avoidance, the main term, so you should try to avoid the process of bleeding entirely and try to control it when it has occurred. Then you should try to avoid any damage to any organ. Then you should avoid diathermy damage. Very important, can be very damaging to the gut. So try to avoid the diathermy damage to the gut. And finally, there should be intense vigilance in the post-operative period. So these are just the basic principles of the surgery that actually apply to this minimally invasive surgery as well. Now, the post-operative care, it includes the care for nausea. So usually these patients have nausea initially, but it improves rapidly. In a couple of hours, this nausea improves, and the patient can start the diet if the patient wants to. However, if the patient is not feeling comfortable, usually this nausea settles by the night, and in the next morning the patient is good to go. Now, shoulder tip pain is actually the referred pain from the diaphragm. So it is not a new pain, so the patient should be told of this. Most of the patients develop a sharp shoulder tip pain 3 to 4 hours post surgery, which subsides the same way it develops rapidly and subsides rapidly. Then the patient can have abdominal pain. Obviously, there's sufflation of the abdomen, there's creation of pneumoperitoneum, there's incisions in the abdomen, however small, but they're still there. So the patient can have abdominal pain as well. Then the patient can have analgesia at the site. Then if a patient has an orogastric tube, usually the patient does not have that, but if you needed to decompress the stomach and you added an orogastric tube, it should always be removed before the patient gets conscious. Now, the oral fluid therapy is very important in these patients. The maintenance of optimum oral fluid therapy is required. Oral feeding can be started as soon as the patient wants. You should always check for bowel movements. Usually, the paralytic ileus is not there as compared to the traditional surgeries, and once you can hear the bowel sounds and there's wind, you can always start the oral feeding. Urinary catheters are usually not required in these patients. They're just to measure the urinary output during the surgery, and post-operatively they're not required, so hence remove any catheters whatsoever. Some doctors, some surgeons, they place drains in the area so that if there's any fluid or any blood, any leakage, it can drain out in through the drain. My professor used to say the placement of drains talks of the incompetence of a surgeon himself. So the placement of drain is not recommended, and if you have to place a drain, the drain should be removed within 24 hours. If a drain is filled a lot with blood, that means there's leakage of the anastomosis that you have produced, and you should revisit and perform. The patient should undergo a revisit surgery. So, continuing with the post-operative care, the skin sutures, if they're non-absorbable, or skin staples, they should be removed after 7 days. The mobility and convalescence, the patient should get out of bed to go to toilet as soon as they can. There's no obstruction, there's no limitation to the patient's movement. The patient should be encouraged to move and go to the toilet by themselves. Now, what is single incision laparoscopic surgery? So, initially with the laparoscopic surgery, there were small incisions, but there were multiple of them. One incision for the camera, one incision for the instrument, one incision for this, one incision for that. So multiple incisions. Now, in single incision laparoscopic surgery, as can be seen in the figure, a single incision has been produced, and through this single incision, all the ports have been inserted, be it camera, be it diathermy, be it the clipper, the instrument, whatever. So all the probes have been inserted through a single incision, and this single incision provides a better cosmetic output because it's only a single incision, and this single incision will heal with the primary intention, leaving minimal scarring. You can perform your procedure the same way. The laparoscopic procedure is not affected, but only the point of entry is affected, and this is from a single incision. Another variety within the single incision laparoscopic surgery is natural orifice transluminal endoscopic surgery. So in natural orifice transluminal endoscopic surgery, you try to go through a natural orifice. So going through a natural orifice gives you a preformed area. Here you can see they're going, this is the vaginal canal. So this is the natural orifice. They have formed a small opening in this, and from this they have entered into the peritoneal area. This is the rectal canal, this is how they have used a natural orifice to enter the peritoneal cavity, and through this they are performing the gallbladder surgery or cholecystectomy. The difficulty with this procedure is that it is very difficult to maneuver the entirety of the peritoneal cavity through that natural orifice, and along with that there's the opening of the rectal canal itself. After removing the gallbladder, you need to close that rectal canal, and the closure of that rectal canal is still not very well developed. The techniques for the closure are not very well developed. So this is not favored by a lot of surgeons because of a lot of the chances of a lot of complications can develop during this procedure. So this was all about this section. I hope you liked and understood this. For further such lectures, keep watching sqadia.com.